Thank you, sir. Thank you, Dr. Sonu, sir, for inviting me in your instruction course once again and giving me this opportunity to share experience on phakic IOLs in low diopters against LASIK and lenticule procedures or PRK. So we all know that myopia, hyperopia, and presbyopia is on a rise. And nowadays, a lot of people want to opt for a cosmetic refractive surgery where they don't have the need to wear glasses. Now, if you just divide the myopia, you have 41% of the patients who are low myopic, which is less than 3 diopters, and then you have 59% who are high myopic and more than 59%. So, like, this is how it happens. So, technically, your 40% of the crowd, which is going to come to your clinic for refractive error surgery, is going to be 40%, and you have to choose the right surgery for them. Now, whenever it comes to refractive surgery, especially low myopia, you always have two options. You have laser-based procedures like LASIK, trans-PRK, SMILE, or you have lens-based surgery to correct the refractive error. Now, low refractive errors always, or whenever a patient has a healthy topography, laser-based procedure is the choice of procedure. However, and it does give us refractive outcomes. But if you speak from an economical perspective, it can be expensive, and because it requires an extensive diagnostic and surgical setup. Sometimes, when you do a laser surgery, it is irreversible in the cornea. Once you have done the laser, you cannot go back and give back the patient the shape what the patient had. So it's irreversible. And you also, a patient suitability may be a stumbling block, which I'm going to come in my next slides. Whereas when you see the lens-based refractive surgery, which is the phakic IOLs, we all know that they do give us good outcomes. They are much more predictable in terms of contrast sensitivity, your safety, efficacy, and your quantity and quality of vision. So, and it is also cost effective because most of us here are cataract surgeons, and we do have a basic cataract setup. So it hardly requires anything more. It's just a tomographer and maybe a digital caliper, but we can do most of the stuff with our existing cataract practice, so it's cost effective. Let's say tomorrow the patient is not happy with the lens-based refractive surgery. It's a reversible procedure. But the biggest challenge here, of course, is that it leads to increased incidence of cataract. But with today's era, if there is an incidence of, there is a cataract, there's a good way to deal with it with the best of lenses available to our armamentarium. So, of course, when it's a lens-based surgery, there's no question if the patient is young and if everything is fine, phakic IOL is the way forward because it does preserve the accommodation. It has a broader range, the rapid visual recovery, and high predictability rates. Now, for low myopia, you'll always have these 4 options: trans-PRK, LASIK, CLEX, and phakic IOL. So let's go step by step of what the advantage and disadvantages are for each of the procedures. For trans-PRK, it is a bladeless single-step procedure. It has less biomechanical alterations, and if we all know that the incidence of ectasias with trans-PRKs are minimal or nil, and whatever biomechanical strength is there today, it's going to be there after surgery most of the times. And the corneal nerve hemostasis is very well maintained. But of course, the patient do have, they're always scared of getting a trans-PRK done because it does pain, and there is a little bit of discomfort, especially in the first 24 hours and until it heals, which may be 3 to 4 days. It is slower recovery in terms of your quality of vision and sometimes quantity of vision. And there's always the most dreaded complication you can have is chances of haze. So trans-PRK is a very good option for low myopic patients, but you have to understand the pros and cons for the procedure before advising it to the patient. And knowing the personality of the patient is the key of it. Now, when it comes to LASIK, all of us are very comfortable with it because it has the wow effect on post-op day 1. 99.99% of the times you don't have to worry because the patients are happy and that's what they want. Day 1, good quality and quantity of vision, and it's a quicker recovery. However, it's a flap-based complication, so if you have any patient who's into contact sports or army or anything, you cannot technically offer this procedure to them. The aberrations do get altered, and if it's a very high myope or if it's a very high cylinder, sometimes the contrast sensitivity can drop. It's a flap, so it drops your biomechanics by at least 20%, and then further based on the refractive error you correct. Low refractive error correction, lesser change; higher refractive error correction, more change. And one thing you have to understand is it's irreversible. So if tomorrow your patient is unhappy, you have to deal with the patient and give them the best possible option but it's irreversible. When it comes to CLEX procedure, again, it's better than LASIK but worse than trans-PRK in terms of biomechanical alterations. It does avoid flap-based complications, so you can give it to your sports people or your people in army or in any with a little bit lower, thinner cornea, and you can do an extra procedure. However, sometimes when it's a very low myope and with newer technologies coming in, sometimes the lenticule is very thin and it makes it difficult for us to identify the plane, remove the lenticule, and sometimes there is a fear that the lenticule may be torn or retained, especially in the edges in very thin corneas. And like LASIK, it is irreversible. But when it comes to phakic IOL for low myopia, I think whatever challenges we have with other procedures is not there here, and but you have vault-related complications, but we do have option of exchanging the lens, which is not the best option, but if something happens, you can do it. So why phakic IOL sometimes for low myopia? Because it's a non-ablative procedure. It is suitable even for thinner corneas, and it's reversible in nature in true sense as compared to the other laser-based refractive surgeries. So now, how do I use this for my benefit? Let's see a few case examples. These are two patients. One is posted for LASIK and the other is posted for ICL. Both have 6x6 vision, but this patient who's undergone LASIK has difficulty in focusing for near because there is a little bit of change in his aberrations and he's not able to adjust to it, which has led to convergence insufficiency, and he has headaches. Whereas because we are not altering anything in the cornea or aberrations of the cornea, the patient with ICL is 20/20 with no photic phenomena. So what could be the reason for this? As I already mentioned, in LASIK, there is always a change in aberrations which may alter your depth of focus, whereas in phakic IOLs, your depth of focus is maintained. Now, whenever you have a low refractive error, when you do your topography and biomechanics, whenever you have a skewed surface like what you can see here, it's not a symmetrical bow tie, there is a little bit of skewing present here on both the eyes, and biomechanics is also on the borderline side. So in such kind of cases, the only two options are trans-PRK or phakic IOLs, but if the patient is not willing to take the discomfort and pain, then phakic IOL is the only option for this patient. This is the patient where everything looks fine. You can go ahead and do the surgery, but what if your patients have keloid? Do you want to take a risk by doing any laser-based procedures? I think the ideal way, as we have more predictable results with phakic IOLs, it's better to avoid any laser-based procedures and go for phakic IOLs, especially with patients with keloid tendency. And if the patients have any dry eye related issues, like everything is fine again here, but the patient has burning and irritation. Whenever they complain of burning and irritation, or especially they say that whenever I wear contact lenses, I have a lot of burning, irritation, itching, that there may be an ocular surface issue present here, and if you do a LASIK on them, it's just going to worsen. And these are the patients where you probably would avoid a laser-based surgery and go ahead with a phakic IOL, because phakic IOLs are known to not worsen the dry eye after the surgery as well. I'm going to skip the videos because Sonu sir's presentation was very good. And last but not the least, whenever there's a very thin cornea, especially less than 470 microns, always go ahead and do a phakic IOL without thinking. So to conclude, phakic IOLs are good options when it comes to low myopia, because it has minimal alteration in terms of aberrations, depth, it maintains the depth of focus, it is a viable option with patients with irregular corneas or any topography changes or poor biomechanics, and they are a safer option with patients, especially when patients have ocular surface disorders. Thank you.
Thank you, Pooja, for that wonderful talk, and I think that clears distinctly between the three procedures. What's the lowest diopter on the ICL that you have done?
Yes.
2.5 diopters.
Yeah.
So I think that pretty clearly spells out that even for low diopters, ICL is quite a safe surgery.
I've done patients where the cylindrical error is a little bit on the higher side, but the sphere is 0.75. But when it comes to just plain sphere, 2.5 diopters. Okay. But for cylindrical power, the sphere 0.75 is what I've corrected.
That's quite reassuring.
Yeah, because I think whenever there's a high cylindrical error like 2.72 or more, we've burnt our hands doing especially with borderline biomechanics and thin corneas. If you do a trans-PRK, there's always a very high risk of peripheral haze. So phakic IOLs are peaceful.
But the only concern is their rotational stability and their placement right bang on the axis. And I'm sure with your hands and with all the devices latest, I mean, the results must have been like.
You're absolutely right, sir, because especially for such low myopic patients, sphere or cylinder, you have more stress because they're technically able to see 618, 612, and if there is a rotational issue, then they are even worse. I think for those patients, my option would be IPCL first because you just keep it at 0, 180 degree, and probably not ICL is what I would probably do it in my clinic. I do that.
Thanks, Pooja.
Thank you.
Sonu, I'd just like to add something. My first exposure to a low-power phakic lens was a couple of years ago. I had a couple from the American Embassy, husband and wife, both were Americans, 2 and 2.25 diopters, approximately both, and they both asked for a phakic lens because they said it's reversible. And that's when it opened the box for me that, okay, I can open these options. So I open these options to patients who come to me for a refractive correction, even at a lower or moderate power. I tell them, here is a reversible procedure. Here is a procedure which costs less, but not reversible. Take your call.
I would just like to add one more point. Whenever there is a family history, first cousins, especially with family history of keratoconus, strictly avoid any laser-based procedures. I think I should add that for, yes.